سيدي الشاشة كويسة شغالة، بس أنا ودك بس على شير من تحت. تمام.
هيك تمام.
تمام سيدي. مساء الخير جميعا، الله يعطيكم العافية. نرحب فيكم بلقائنا الأسبوعي. محاضرتنا اليوم عنوانها كون جيت باترنز ان سي بي مع دكتور راشد طلونة، أخصائي أول عظام بيدياتريكس، مستشفى الملكة رانيا. دكتور راجل تفضل سيدي، الله يعطيك العافية.
شكرا لك نصر، الله يعطيك العافية ويعطيكم العافية جميعا. آم، الله يمسيكم بالخير. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أكرم المرسلين. موضوعنا اليوم حلو وممتع، عن common gait patterns in CP. في له pre-requirements قبل ما أنا أحكي إنه أنا what are the pattern gaits in CP. لازم أكون بعرف كم شغلة بديها. نتدرج في الموضوع درجة درجة. هلا في شيء بنحكي مرات walking بنحكي gait. Are they the same? Well, walking on two legs is something that distinguishes the humans from other mammals. هذا الشيء اللي بيميز الإنسان، اللي هي القامة، إنك واقف، إنك بتمشي على بقامتك. Um, the most common question بالpediatric orthopedic clinic وبالneurology clinic أو خلينا نحكي from a parent with a child with CP. The most common question and the most essential question وأكثر سؤال الأهل are really concerned من أول يوم بيكتشفوا إنه المريض عنده سي بي أو طفلهم فيه عنده شيء غلط. هذا أهم سؤال. Will my child walk؟ هذا السؤال اللي بيسألوك إياه. Now, going into what is walking and what is gait. عشان نقدر نجاوبهم لازم نكون إحنا فاهمين شو اللي بنحكي عنه. Walking simply is advancing on feet on bipedal locomotion. يعني انك to use your feet to advance, to move from one place to another. This is the simplest definition of walking. بس احنا دائما ما بنقول والله abnormal walking، بنقول abnormal gait. لانه gait is the way you walk, the style of walking, the shape of walking. يعني الترجمة بالعربي عشان نفهمها أكثر: walking المشي، gait شكل المشي. كيف كيف لما دائما انا بحكيها، زملائي اللي معي بالتيم دائما بيسمعوها هاي مني. كيف لما تروح واحد، هذا شيء معروف بالمجتمع، يعني واحد بيروح اول يوم على الجيم بيلعب له شويه حديد او شويه رياضه، بتلاقيه بيطلع نافخ حاله. كلمه نافخ حاله هاي this is a pattern of gait. رافع ايديه وبمشي وبتمايل. This is gait. This is the pattern of his gait describes something else، انه دماغه قاعد بفكر بالطريقه هاي. احنا معظمنا عسكريين، وفي عندنا مثلا المارش او المشيه العسكريه، شيء مشي سريع مشي بطيء بتحرك ايديك امام خلف. This is a pattern of gait. It represents, it always, pattern of gait always represents some other higher function, whether normal or abnormal regardless. يعني ايش؟ the brain wants you to walk in this gate. عشان هيك انا اتخذت قرار دماغي وودى رساله للسباينال كورد على شيء اسمه central pattern generator، و AI produced this pattern. Now sometimes this pattern is abnormal. هلا بنشوف كيف بعض الحالات، بس في دائما قبليها how does we have to know how does gait happen, how does it happen. حكينا في عندنا شيء اسمه central pattern generator. central pattern generator هذول مجموعة خلايا عصبية afferent efferent. They meet in the spinal cord and they produce a pattern. There is a prerequisite for them انه ايش؟ لازم يكون عندك supra spinal center in the CNS اللي هو ايش؟ احنا بنعرف الموتور كورتكس. هلا الموتور كورتكس، او خلينا نحكي supra spinal centers، ما حكينا center. لأنه mainly concern what we are concerned بالbrain with regards to movement, voluntary movement, whether gait or walking or anything. But the one that produces gait, motor cortex, البيزل ganglia والcerebellum. كل واحد initiation of movement أو need of movement أو how muscles move تطلع من الكورتكس. cerebellum makes it steady, sharp, no shaking فيها، ما فيها balanced move. البيزل ganglia بالنص وصله بينهم to organize the move. How is it going؟ ما عضلة تشد أكثر من الثانية. فهاي أشياء simple how to understand how do these patterns happen. It's just some sort of organization in between these systems to produce this pattern. So also gait has some determinants اللي هي pelvic rotation. ما راح أفوت بهدول الدefinitions بس you have to understand them and you have to know them. Pelvic rotation, so the pelvis rotates to determine how the gait comes. Pelvic tilt, lateral displacement of the pelvis. So the pelvis actually إذا بتتفرج على واحد بيمشي من ورا وبتشوف كيف بيمشي أو بتسوي analysis لنقطة وبتحط center of pelvis وبترسم خطوط على كيف عماله بيمشي. The pelvis displaces right and left مع كل step أو كل cycle of steps displaces. So this displacement is one of the determinant of gait. The flexion of knee and the foot and the ankle motion. كل هاي الأشياء مع بعضها it determines how your gait is. And there are some requirements. A control system. In our case بحالة مرضى cerebral palsy it's defective. So one of the requirements of the system of the gait is defective, and we'll talk later on about some patterns and how to differentiate between things. Energy source, which is not an issue in cerebral palsy patients. Usually, most of the time, it's not an issue. Levers providing movement. شو يعني lever? Lever arm يعني زي any muscle that moves, it needs any joint that moves, it's a lever. Actually, we're all levers. كل جسمنا levers. Muscles مرتبطة بمكان, it's all levers. Usually in cerebral palsy patients, they are born with a normal levers, but during development they develop into abnormal position. ليش؟ نرجع للبيسكس of orthopedics. Volkmann law. Bone remodels according to the stress applied to it all. فهاي because because of the forces of the joints or surrounding musculature around the joints, and these forces they produce abnormal patterns in which bone will simply just remodel as a biological reflex into an abnormal position. So that's partly the issue in these patients. And then you need more forces to move the levers. So what are the factors, the other factors that affect the gait that we have to keep in mind? Simply that these patients, other than the biological issues, they might have problems in standing. If a patient has problems standing, how do we expect him to walk properly? And there's a fear of falling. So you can't put this on the patient. You have to understand that the patient is afraid of falling rather than when you're testing him, when you want to analyze it. So we have to understand that this is part of the issue. They have also poor stability and counterposing, absence of lateral sway when they walk, lack of tilt reactions in standing, lack of protective reactions. So understanding these things makes you take them out of the equation when you analyze a pattern of gait. So before we proceed into these gaits, why do we need to look for patterns, to gait patterns? Because if we understand the pattern, we identify what the patient has, it helps us with the diagnosis. We need to document it. And then this documentation leads you to, guides you into the progression. Is it improving? Is it steady? Or is it worsening? And identification of a pattern makes you understand what's wrong with this patient and then helps you prevent worsening, maintain function, or even, which is the ultimate goal, to improve the function. Now, going into the main subject. So before going into it, we have to understand what are the types of CP. So CP simply بناء على قبل شوي حكينا في centers responsible of controlling شيء اسمه central pattern generator اللي بيسيطر عليهم هدول 3 مواقع رئيسية بالدماغ. كيف تطلع شكل مشيتي ومشيتك ومشية أي واحد بالشكل اللي هي بتطلع فيه، اللي هم الموتور كورتكس، basal ganglia, cerebellum. Now, according to which part of the brain is affected, بيطلع عندك which type of CP. Spastic اللي هم بيكون عنده الموتور cortex which is affected, which is the most common by the way. It either comes hemiplegic if one side of the cortex is affected, diplegic both sides. Dyskinetic, so these dyskinetic بيكونوا ايش؟ The affected part is the basal ganglia, in which if it is the affected part, they have involuntary movements. They simply their movement is involuntary because there's no control in between the road between the motor cortex and the cerebellum to have the end result. ما في كنترول عليها، فبيكون عندهم حركات لا إرادية بالنتيجة. Ataxic type, the problem is in the cerebellum. نعرف كلنا وظائف الcerebellum. Mainly balance, to make the movement smooth, not shaky. And we have also the mixed part. The mixed type, المixed type اللي هو شو؟ Simply because CP initially is an insult to the brain that happened at one, or at least one incident, but it happened there and that's it. It doesn't progress, the damage doesn't progress. It's not like a disease that progresses. إشي صار، حدث صار بالدماغ وصار ضرر وبناء عليه احنا بنشوف كل تبعاته. in reality CP اللي احنا العظام بنعرفه هم هذولا، بس in reality cerebral palsy اي مكان في الدماغ تاثر it is part of cerebral palsy. بس احنا كعظام this is what really involves us. any spot في البرين لو تاثرت منطقه فيرنكس تراينجل، السبيتش، الهيرنج، اي شيء بتاثر هو اللي بيكون فيه deficit. بس احنا we're not really concerned about it, so we don't really get exposed. بس هدول المناطق اللي احنا بنعرف احنا كاطباء عظام we are exposed to it, so this is the analysis of that. Spastic, dyskinetic, ataxic, and mixed, which is when the injury just happened or the insult to the brain happened all around or more than one spot. Okay. Now, spastic hemiplegic patterns. Spastic hemiplegic and spastic diplegic, each one of them has 4 groups. These 4 groups are actually how better or worse is the patient. نبدأ فيهم. Spastic hemiplegic يعني one side is affected. So you look at the patient, فرج, the child comes to walking to you with a drop foot, simple drop foot. So that's the group 1 or grade 1. And then the more worse type of that is when a child has an equinus, which is unilateral, but it still hasn't affected the knee. Now, group 3, they call it jump knee. The problem is that the knee is actually just in a fixed position and the ankle is in equinus position, and that produces some sort of a pattern. هلا راح اورجيكم فيديوهات كلهم بس I'm just mentioning them. Group 4, you have the whole 9 yards when you have equinus, jump knee. Jump knee يعني احنا flexion of the knee. He cannot extend the knee. And then you have pelvic rotation زي ما احنا شايفين بالاكس-راي. There's a problem with the rotation. The hip is slightly flexed. adducted, internal rotated زي ما بآخر صورة هنا. This is how they would look when they're standing. Now let's go to the videos. So there's an increased tone, stiffness, spasticity on one side of the body in these spastic patients. And this is how a child, and that's the left side, that's how a child would look, the gait would look. There's a drop foot. So remember, I'll just keep on repeating it while I'm talking. So remember that this is not the drop foot of an injury. This is a drop foot because of the function of the nerve, which is supplied by this area of the motor cortex. So that's the left side drop foot, which is a fairly simple type, but that's the deficit. That's it's been affected. So it's spastic, hemiplegic, a child with a drop foot gait pattern. Now I understand what this child has just off the pattern, and I can expect the natural history, and I can talk to the family, tell them what this child needs, what I expect. So this is just by the gait pattern in this child. I can explain everything. I can expect what's going on just by understanding what is the gait pattern in this child. Now, going into equinus. So this child has an equinus in his foot, or in her foot, I think. And it's spastic hemiplegic. But the knee still can extend. So this is how I would expect a child with a type 2 gait pattern to walk. This is the gait of a type 2 in which it is equinus, true equinus of the Achilles tendon, or true equinus of the ankle joint. But it's still, so I look at the joint above, so it still can extend. So this is still type 2. And this is another pattern. Now, going into jump knee, it is a distinct pattern. If you see it, you'll understand it. So the knee can't really extend fully. She's trying, but it's still tight. I hope it's obvious, but she can't really, or he, I don't know. So that's type 3, and they call it jump knee, or inability to fully extend the knee while you're walking, in which you will lose the home locking mechanism in the knee joint when you fully extend, and the ankle is in equinus. Now, type 4, equinus, jump knee, and the hip is adducted, and this is the full-blown picture. And that's grade 4, equinus, jump knee, hip adducted. There's a problem with the rotation and the tilt. I think it's obvious that the problem with the rotation it's unilateral, which means it's hemiplegic, spastic hemiplegic. So by reaching this, I can understand where is the problem, and then I can tackle what are the next step and plan my method of treatment. Okay, now we've finished the hemiplegic. Now going into diplegic. So both sides, both cortices are affected. So this child has bilateral issues. It starts by the group 1 or grade 1 is true equinus, and then group 2 is jump knee. So we meant by jump knee that the knee is flexed while I'm walking. I cannot extend it fully, and the ankle is in equinus. Now, group 3 has something that we have to understand, which is apparent equinus. So it's not true equinus. The foot looks in equinus, but the problem is the knee has become so much flexed, in a position so much flexed, that the gastrosoleus complex is collapsing, and the child has gone down to a point where the knee, because of how much the knee is flexed, the ankle appears to be in equinus position, but it's not really in an equinus position. And then group 4, which is the crouching gait, which is, I'll show you now videos, what is a crouching gait, which is fairly just like the group 1 and hemiplegic, but in bilaterally. Now, true equinus. So this child, so to be able, look, before starting the video, to be able to put the heel back, he has to lean back on something, because he just, otherwise he would fall down. And if he wants to stand, he has to bend forward. So look at how to put the heel back, he has to bend as much as possible to balance himself. So that's true equinus. Bilaterally, to put the heel back, he has to bend to balance himself. Again, bilateral, so spastic, diplegic, group 1, equinus. And that's true equinus. Going into type 2. So the video is not working. Apologies. This one is not working. I'll try to find it. Okay, now going into, okay, so the video doesn't seem to be loading. I have some technical issues with that, but still, I have to explain it again. So you have to understand apparent equinus is not a true equinus. So true equinus is the gastrosoleus complex, or the Achilles tendon is simply tight, and it's just in equinus position and it's tight. But apparent equinus, when you look at the patient, that you feel that it's an equinus, but it's not really an equinus. It's just compensating for the knee, because it's so much flexed that the ankle, the heel is lifting up. So you feel it's a true equinus, but it's not a true equinus, just to compensate for the position. Now, crouching gait, what happens? زي ما حكينا, muscles eventually will fail. So when you're tiptoeing, you can't just tiptoe or walk in this equinus position, or in this jump knee position, or apparent position. You can't do that forever. Eventually, something will give up, and it will be the soft tissue that gives up. You will either have a midfoot breach, gastrosoleus complex failure, or some sort of procurvatum in the knee. Something will give up in the soft tissues. Now, and that's what the crouching gait is. So the crouching gait, the gastrosoleus complex has failed, and the child has just gone down all the way. And that would be the gait of a crouching gait. So bilateral, which is diplegic, spastic, and that's the crouching gait. Okay. Now, I have to mention there are some other distinctive gaits, which is something we call scissoring gait. So this is how a child would look like. It may come with any type of them. People think that or some of us think that it's just the adductors are tight. Well, that's partly the issue, but it's not just the adductors. It's simply part of the whole imbalance, the spasticity that the child has, and the development of a bone, the abnormality of its development of bone, and the inability to regulate the gait properly, along with the other issues. So this is typical spastic scissoring gait. So understanding these patterns makes you understand what you really need to do. Okay. Now, the other type is so we finished the spastic gait patterns. Now, a little bit about the dyskinetic, which is the chorea gait. So we said that dyskinesia or dyskinetic gait is associated with which type of the brain? The basal ganglia. So we will have some sort of chorea or abnormal movements when we're walking. So because the brain is just simply not, the intention is there, the motor cortex sends some messages when it reaches the basal ganglia, or sometimes the basal ganglia just initiates some involuntary movements. So that's the best word to say to describe it. So it's an involuntary movement. And this is, again, how the pattern would look like. So we understand that the problem here is at the level of basal ganglia. It doesn't really give me make any difference on the prognosis, actually, just understanding it. But you know what the problem is now. You know what he has, and you know how to tackle to plan what's next. What are the progression of the disease or the progression of his whether improvement or worsening, and you can prevent worsening as much as possible. And that applies to all of them. And this is again, last time for dyskinetic chorea gait. Ataxic gait. So ataxic gait is the gait of a drunk man, or drunk person, sorry, not a man at least. A drunk person. How is it? Because the cerebellum does the problem is in the cerebellum. So the cerebellum is not functioning properly. The basal ganglia is sending is regulating the message from which is coming properly, at least from the motor cortex. But when it reaches the cerebellum for execution, it's just not shaky, not non-steady. So this is how a child with an ataxic gait, which means that the affected part is the cerebellum, this is how a child would walk. Shaky, balance is barely achievable. So the message is fine from the motor cortex. At the basal ganglia level, it's still fine. But when it reaches the soothing or the sharpening of how the movement is smooth or how balanced is this move, it reaches the corrupt message from the cerebellum, and then this is what we get. Okay. So take-home messages. Gait pattern describes the style of walking, the shape of walking, the manner of walking. شكل المشي, that's what we mean by gait pattern. So we understand now that many factors affect it. Some of it is indigenous to the patient. Some of it is a concern from around the patient. We have to understand the patient might have some fear of falling, some social issues. You have to understand these issues, and that's why you're an orthopedic surgeon. You have to read the room and understand how is the condition of his child and what are his abilities, and Even sometimes, if you want to examine him, you might examine him from another room and see him how he's walking, or distract him, or whatever you need to achieve the goal of understanding or making these fields a way so you can understand this pattern of gait pattern. And the important message of the whole lecture today is understanding that if you identify the pattern, it guides you to how to treat this child. والله يعطيكم ألف عافية. بتمنى يكون الأمور واضحة. إذا في حدا عنده أي أسئلة أنا جاهز.
الله يعطيك العافية سيدي، محاضرة رائعة، واضح كل شيء فيها. أي سؤال
الله
شاذ
يعافيك.
دكتور رازي؟ أي سؤال؟
ما فيش ولا سؤال، معناها يا اما يعني يا اما كل شيء كثير واضح which is rare، او ما حداش فاهم شيء which is fairly common. بتمنى يكون الاول الصحيح
إن شاء الله سيدي الخيار الأول إن شاء الله.
ان شاء الله. Okay, so are we sure no one has any question?
يعني يبدو هيك سيدي.
تمام، ولا على الشات ما في اي شيء؟ حدا حاب حاط شيء عندك ناصر؟ انا مش قادر يطلع عندي الشات ومش عارف كيف طلع صراحة.
لا كأسئلة ما في، بس يعني تعليقات، بس ما في سؤال سيدي. لا
يا اكيد على طول، اذا اي حدا بده سؤال انا جاهز.
لا كأسئلة ما في، بس كل بعض يعني نشكر بالمحاضرة سيدي، الله يعطيك العافية.
الله يعافيكم جميعا، شكرا لكم على وقتكم. أنا آسف إذا أطلت عليكم كثير، بس يعني شعرت إنه لازم أفصل بالموضوع عشان نوضح قديش الموضوع سهل جدا.
لا لا سيدي، وقت مناسب، الله يعطيك العافية.
الله يعطيكم ألف عافية جميعا، وشكرا لكم على حضوركم.
لا سيدي كل شيء.
أهلا وسهلا.